The question that came to me is, does the amount of energy applied have an effect on IOP reduction and the duration of effect? And we do believe that the amount and duration both have an effect. The amount of laser energy applied determines if an effect is achieved. So in order to get the effect of pressure lowering, you need to hit a certain amount of energy. And it also has some influence on the duration of pressure lowering. Once a good effect is achieved, my experience has always been that the duration goes for a very long time, if not indefinitely. Low total energy results in a lack of efficacy or sustainability, and you do have more lasting effects the more energy you use. And Sanchez and colleagues, including a few folks here on our panel, looked at 22 eyes, 17 patients with glaucoma of various types and stages, followed them for 7.9 months on average. And all patients got 2 watts of power at the typical duty cycle, 31.3%. But the treatment duration varied from 100 to 180 seconds. And as you can see, those eyes that had the higher amount of longer duration of therapy ended up having a sustained success and achieving about 80% success, up to the end of the study period. Whereas eyes that received 100 seconds or somewhere in between didn't have either as high a responder rate or as long of an effect. So that's the lesson from there. Success was defined as it typically is, 20% pressure reduction, not in a hypotony zone and no secondary surgery. And you got the 75% successful with 180 seconds, 21% successful with 160, and no real sustained success with 100 seconds only. So we think there's a threshold that 180 seconds was a good place to go. And most importantly, the higher amount of energy didn't create any problems in terms of safety, so no complications. So that's one piece of information. A little bit of this, now we'll kind of look at the work of Murray Johnstone and just talk a little bit about how the laser works. It causes contraction of the longitudinal ciliary muscle fibers, specifically the longitudinal ones. That tightens a scleral spur, results in a possible prevention or opening up of the canal, preventing collapse or opening it up. And have some kind of nice images from the work of Dr. Johnstone here. So we're looking at a cadaver eye, and you can see the contraction of those longitudinal fibers as the laser is applied. And it's quite remarkable in this experimental setting. This is obviously the probe being placed against the sclera, and you're seeing the action on the ciliary body below. Dr. Johnstone concluded that ciliary body motion begins to occur at very low energy levels, and ciliary bundles shorten and then lengthen again. So there's sort of an interaction between the laser tissue, and MicroPulse laser causes the contraction. And ciliary muscle bundles only partially lengthen. The thermal effects are going to be long lasting, and the tissue changes are confined to the longitudinal part of the muscle. And he does not see the ciliary epithelium being involved in the MicroPulse in any of his studies, indicating that we are treating here the ciliary muscle, specifically the longitudinal fibers, and that we're getting a pilocarpine-like effect, and that we're opening the angle. So this is an outflow mechanism, or at least for Johnstone's work. Finally, I talked about varying the duration of therapy, but there's another way to change your power settings, which is to go up in the power. Now, this was, again, with the first probe that came out, but I treated a number of patients and found that there's 73 patients, all of them followed for over a year. I used 100 seconds total, which I recognize is a shorter amount of time than you've seen in other studies. But I varied the power by going up. And when I used a higher setting of 2,500 milliwatts, I got 57% pressure reduction on average, and I got a 30% reduction at 2,000 milliwatts, indicating that there was, in fact, a dose response curve to the amount of energy. Again, just on average, I got the pressure from about 26 down to say 15 or so. And again, this is out to 2 years. And you can see that really good stability between 1 month and 2 years. This is the dose response showing that I had the highest amount of response with 2,500 milliwatts, that 2,250 and 2,400 were somewhere in between, and that 2,000 got me, that sort of 20 to 30% pressure reduction, but clearly wasn't as efficacious as 2,500. So we know there's a dose response curve related to both the duration of treatment as well as the total energy. And again, that dose response curve was present from 1 month, 3 to 6 months, and out to a year. So summarizing, we know that longer duration increases efficacy without a safety cost. Higher energy aids efficacy, and that response is present 1 to 2 years later. Dr. Johnstone has shown that this is an anatomical change and not something that we're doing to reduce aqueous production on the ciliary body epithelium. There is a lower limit of energy, and if you don't get above that threshold, you may not get a pressure lowering effect. And this could be because the total energy is too low to get the threshold of tissue impact. As Dr. Johnstone showed, we want to get those longitudinal ciliary muscle fibers. And when we are subthreshold, we may have a reversible effect that doesn't stay.